Arshad from National Institute of Mental Health and Neurosciences, India, talking about neuroimaging signatures of behavior, cognition, and frontotemporal dementia spectrum disorders. So, hello, Dr. Faheem.
Hello, everyone. Hi, Shaima and others. So, thank you so much, organizers, for speaker for this webinar. So, I am Faheem from India. I'm a neurologist from National Institute of Mental Health and Neurosciences, India. So, I'll be speaking on neuroimaging signatures in frontotemporal dementia. So, can I share my screen?
Yeah, sure.
Are you able to see the screen?
Yes.
Don't worry, Peppa. I'll make sure the birds don't eat the seeds. Good luck, Daddy. See you tomorrow. Bye. This is nice.
So, frontotemporal dementia, again, it's one of the neurodegenerative diseases commonly characterized by behavioral changes as well as emotion cognitive impairments. We know most common dementia is Alzheimer's disease, but after that we have either it's vascular dementia or FTD or DLB, depending upon the region wherever you see dementia. FTD is a very complex disorder affecting social connectivity between brain regions, and at the same time it's very heterogeneous, consisting of classical and overlap FTD syndromes reflected in different clinical phenotypes. So as I said, it could be even the second most common cause, or in fact it may be third. It would really depend upon the region wherever you are studying dementia. And around it constitutes about 10 to 20% of all the dementias worldwide, and the prevalence is around 15 cases per 1 lakh population aged 45 to 64 years. Now, this is a spectrum of frontotemporal dementia. It's not that simple. It's very complex. It has classical variants, which include the behavioral variant, the PNFA, and semantic dementia, and then we have the overlap group, which contains the FTD MND, FTD CVS, and FTD PSP. So, frontotemporal dementia is not a single disorder. It's a heterogeneous disorder. It's a complex thing, which I think yesterday also Dr. Michael Posson said that all these dementias are very complex. They are more of an overlap syndrome rather than a single entity, and the pathology is different, and the clinical spectrum also becomes different according to the pathology. Now, coming to the background of this study, which we did in our institute, basically there's the definition of dementia has changed. Initially it was the DSM-4 criteria, and now we have the DSM-5 criteria. And the difference being there is one component which has been added in the DSM-5 criteria, which is the social cognition. The social cognition is basically how do you understand others? It's understanding others' emotions, understanding what others think about you, and then trying to understand others' perspective. The social cognition has not been studied in overlap FTD syndromes, though it has been studied in behavioral variant FTD, which is one of the classical FTD syndromes. And what our main aim in this study was to see what happens to social cognition in overlap FTD syndromes. We already know in behavioral FTD cohort, the social cognition is already impaired. So our aim was to see what happens in overlap FTD syndromes. As we know, in both behavior and cognition are impaired in classical FTD, and thus the emerging evidence suggests that their neural correlates are specific. While we don't know the neural correlates of overlap FTD syndromes, which include FTD PSP and FTD ALS. So these social cognition deficits are also understudied, they're under-recognized in overlap FTD syndromes, though it has been studied in ALS, but it has not been studied in overlap syndromes like FTD ALS, FTD PSP. Because ALS itself is a separate entity, and when you have overlap FTD ALS, it's different. It has not been studied in overlap FTD syndromes. And some studies have, although they would have studied this, but there have been some limitations. Now, in order to overcome the limitation, we try to study the whole spectrum of FTD subtypes, including the overlap FTD syndromes in a single study. So, because from a clinical perspective, socio-emotional alterations occur early in the evolution of FTD compared to patients of AD. Though in advanced stage, even AD can have behavioral disturbances, but we need to differentiate AD and FTD during the early stages, because you would have heard from yesterday's talks, because there's a lot of overlap between the syndromes, and behavioral disturbances can occur in either of the two. But if the social cognition is impaired in FTD, in that patient who has dementia, so it points more towards frontotemporal dementia rather than Alzheimer's disease. Though patients sometimes can have, of Alzheimer's disease can also have impaired social cognition. So improved understanding of brain dysfunction that result in these alterations could potentially drive development of new diagnostic and therapeutic biomarkers for disease detection and tracking prior to the onset of irrecoverable brain damage. So we want to do an early diagnosis. As we know, once it goes out of our hand, we may not be able to cure it. As you would have heard from previous lectures, yesterday's lectures as well, we are in search for a cure, but unfortunately we are not able to find it as of now. So we studied the patterns of brain atrophy in FTD spectrum disorders using Voxel-based morphometry, and then determined the neural correlates of behavior and cognition in this group of disorders. So it was a prospective study which we did in our institute for a period of 2 years, and we had a total of 75 patients, but we included only 60 patients because they fulfilled our inclusion criteria. So we used these methods of general cognition, which include Cat and Brooks cognitive examination and the Indian semantic battery. And then in behavior, we use the frontal systems behavioral scale, which assesses the behavior of the patient before and after his illness. And then the most important, the social cognition, that is in social cognition, we mainly include 2 tests which have not been incorporated as of now in our clinical settings, which include the pictures of facial effect that was based on the Paul Ekman's faces, and the empathy, which is the interpersonal reactivity index. So for POFA, this is we show pictures to the patients and ask them to recognize faces, where it's a happy, fear, surprise, sad, disgust, neutral faces. And in empathy, we see their empathic concern, their perspective taking, their fantasy scale, and their personal distress before and after the illness. This we ask from the caregivers. POFA we do directly for the patients. So this was an inclusion criteria. We took patients of age more than 40 years. They were willing to participate in the study and fulfill the standard criteria of FTD syndromes. And we excluded patients who didn't want to be a part of the study. Non-cooperative patients also were excluded, and patients with metallic objects, and advanced FTD with a CDR as a clinical dementia rating scale of more than 2. So this was the criteria which we used for classical FTD syndromes. Classical, which I already mentioned in the prior slides, is the behavioral variant FTD. PNFA is progressive non-fluent aphasia, and ST is semantic dementia. And then the overlap, we have FTD PSP. PSP is progressive supranuclear palsy, and AL is amyotrophic lateral sclerosis, along with FTD. So these were the sets of criteria which we used in our cohort to diagnose FTD spectrum disorders. And then we did the neuroimaging, which is a whole lot of complex process, looking into their brain, exactly which areas are atrophied, which areas are preserved. So then coming to the results, what we found in terms of the demographic profile, the mean age of the cohort was 59, mean duration of symptoms was 34 plus minus 4, and then mean years of education was 10 years, 7 subjects were illiterate, and all subjects were in the mild to moderate stage of dementia. So if you see the cognition, almost all of the patients were impaired in their general cognition, which we did. And general cognition tests 5 things, which check for attention, memory, visual, spatial, and then we also check for social cognition. And in this, if you see the general cognition, it was almost impaired across the whole cohort, and fluency was predominantly impaired in patients of language variant, that is the PNFA, compared to other groups, which was statistically significant as well. And the post hoc analysis revealed significant difference in the subscores of language between BVFTD and ST. ST is semantic dementia, and this was very obvious because semantic dementia people and PNFA people, they have difficulties in their language. And then the FRSB score, this just tells us about the gross behavior of these patients before and after the illness. And it has 3 components. One is the apathy, then you have the executive dysfunction, and then the disinhibition. All of them were impaired before and after the illness across all the cohort. Then this was very important, social cognition, which was the main priority. And we found that it was impaired before and after the illness for all the groups, especially it was impaired for FTD PSP group. And though there was no significant difference in the after scores across all subtypes. But in the post-hoc analysis, we found a difference in the after illness scores between FTD-ALS and FTD-PSP, that is between the overlap groups, not across the other groups. And predominantly it was affected in FTD-PSP group. And then if you see the emotions, if you see in the majority of the cohort, in the whole cohort, happy emotions were recognized better compared to other emotions, especially negative emotions like sad, disgust, fear, anxiety. Patients had much better scores in terms of positive emotions compared to negative emotions. So then what we did a correlation of all the scores, and we found that ACE and POFA correlated. There was a positive correlation between these two scores across the whole cohort, except FTD-PSP, where we didn't find any significant correlation between ACE total scores and the POFA total score or IRI. Although it was also one of the overlap FTD syndrome. This was one of the different findings which we had compared to previous group, which has not been reported as of now. Then when we did the imaging, we found multiple areas of atrophy in all the groups, especially in DVFTD. We found the right lingual gyrus had significant gray volume matter reduction. Then in PNFA, it was hippocampus, right fusiform gyrus. Then in semantic dementia, it was left lingual gyrus, right insula. In FTD-ALS, it was right lingual gyrus, left cingulum. And FTD-PSP also, we had multiple areas. But the important thing here was that gray matter difference in the lingual gyrus between BVFTD, ST, and FTD-ALS compared to other subtypes. And then in addition, there was a reduced gray matter volume in FTD-PSP in cerebellum. So in FTD-PSP, we had cerebellum and thalamus compared to other subtypes, whereas we had lingual gyrus between FTD-PSP, ST, and FTD-ALS compared to other subtypes. Then when we see here the correlation, when we correlated the emotion scores with their gray matter density, we found that a positive correlation between happy emotion and the right lingual, right parahippocampal gyrus and cerebellum interior lobe. And for sad, we found putamen, thalamus, bilateral hippocampus. They are all correlated. Left putamen correlated positively, hippocampus correlated negatively, and discussed correlated positively with left putamen. In addition, no other subcomponent showed any correlation with any other regions. Then when we looked into the IRI, which is the interpersonal reactivity index, which is again one of the components of social cognition, PT's perspective taking, and it correlated positively with left insula, bilateral lingula, bilateral pulmonar area, thalamus, and bilateral hippocampus. These are all areas of the brain. And then EC is empathic concern, which correlated positively with the right amygdala, right hippocampus, bilateral thalamus, left putamen, and the cerebellar structures. So if you see, there's a diffuse involvement in the brain, which showed a positive correlation of social cognition with those areas. So coming to a brief discussion, so these FTD spectrum disorders we observed as social cognition deficits are characterized by empathy and emotional cognition in the overlap FTD syndromes as well, which was relatively similar as has been observed in our classical FTD group as well as in literature. Most severely affected subtype for language and fluency scores were PNFA and ST compared to BVFTD and FTD-ALS, FTD-PSP. The language variants of FTD present disproportionate relatively isolated deficits in expression and comprehension of language. These results support these findings. As I already said, these are language variants, and so they had impaired language domain compared to other groups. When we see FRSP, the behavioral profile shows significantly higher scores after the onset of disease, means they were significantly affected after the onset, and empathy disinhibition were most affected in behavior and FTD, as shown in the previous studies, and FTD-ALS as well. Similar findings were seen in ALS, but in our patients, it was FTD-ALS. Previously, it has been reported only in ALS patients. In addition, executive dysfunction was most affected in PNFA and semantic variant, which is consistent with one of the previous studies. So social cognition, as I already said, it showed significantly low levels of empathy in our cohort, and then our findings of impaired empathy in BVFTD-ST is consistent with the previous study. Similarly, in FTD-ALS also, the social cognition domains were impaired. And if you see in behavioral domain also, in PNFA, there's uncertainty in empathic changes, and such changes have not been observed consistently in previous studies. Sometimes they find PNFA, they don't have an impaired social cognition, their social cognition may be preserved, but some studies have shown it is not preserved. We also show that the social cognition is not preserved in this cohort of patients. And then FTD-PSP, which is the progressive supranuclear overlap FTD syndrome, they're significantly impaired PT and EC, and this is one thing that's not been reported earlier, and the brain involvement is predominantly subcortical, involving the thalamus and the cerebellum. So classical FTD syndrome have shown significant impairment, and then negative emotion, as I said, were more affected compared to positive emotions in classical FTD syndromes, and then in overlap as well, we found negative emotions were more impaired compared to positive emotions as well. Overall, FTD PSP group had impaired emotional recognition compared to the other groups. Then when we see the neuroimaging, FTD PSP had a lower gray matter volume in the bilateral cerebral hemispheres compared to the other subtypes, which may be explained with the fact that the atrophic pattern is predominantly subcortical in patients of progressive supranuclear palsy. And the VBM, which is the Voxel-based morphometry, it showed significant gray matter volume reduction in the lingual gyrus in FTD ALS, BVFTD ST compared to FTD, PSP, and PNFA, again, which is one of the novel findings. Then we found a positive correlation of empathy with bilateral temporal lobes, and then recognition of disgust correlated with left putamen in our cohort, and this disgust recognition is associated with insula and basal ganglia in previous studies observed in patients only of Huntington's disease are following focal damage to insula and putamen. This has not been reported in neurodegenerative disorders. In addition, we demonstrated correlation of left putamen in sadness, recognizing emotion of sadness, which has not been observed in the previous studies. In addition, the neural correlates underlying the recognition of positive emotions still remain elusive and is likely to be non-specific, as has been shown by previous studies. So our study had some limitations, though the overall sample size was comparable to the previous studies, but the individual FTD subtypes had very small sample size. The availability of controls would also have strengthened the findings from the study. We didn't have healthy controls in our study, and obviously, if controls would have been there, it could have been much stronger. BBM has obviously potential confounding factors, including misregistration, extraaxial tissue confounds, and tissue misclassification. However, we took utmost care to overcome these confounding factors during imaging analysis. So to conclude, these findings suggest deficits in behavior and social cognition across the FTD spectrum disorders, and variable patterns of atrophy seen across various groups. Even if you search literature, there are different patterns of atrophy seen in FTD, but predominantly it is the orbitofrontal cortex, the medial cingulate, and the dorsal prefrontal cortex, which are involved. In addition, temporal lobes are involved in progressive non-filament aphasia and ST. And I think those are some of the important areas which are involved. And the important thing is to see whether social cognition really does correlate with those areas. In our patients, it did correlate in some of the areas. However, only important finding was that the emotion of disgust correlated with putamen. So in addition, deficits in general and social cognition, it correlated significantly with different areas of brain, suggesting involvement of multiple areas in different subtypes. And this, as I said, a significant novel finding was that left putamen as a neural correlate of disgust and sad emotional cognition in our patients. Thank you. Thank you very much.
Thank you, Dr. Faheem. Thank you.